Thank you very much. It's my pleasure to be here, and I want to thank Bob Geiser, my good friend, for inviting me to speak. I told Bob when he invited me, I said, Bob, I don't really do OB anymore. I work in cardiac and critical care. And he said, oh, come on, Jamie, you can think of something. And so we talked about a few topics, and pulmonary hypertension is something that there seems to be a fair amount of at UCSF because of our referral base. And so I thought I would talk a little bit about that for this audience. I would also like to mention that when I was a resident, you might have detected a Canadian accent. I was a resident at McGill in Montreal, and my mentor in OB was Sally Weeks. Some of you might know Sally, who's now retired, and she was the one who made me stay in anesthesia. I was actually doing a few months as a Canadian program to be a GP anesthetist, and she said, Jamie, why don't you just stay and keep doing this? So I want to thank Sally, and through Sally I actually met Saul Shnider here in San Francisco, which was a great honor, an amazing man. So it really is an honor for me to be here speaking to all of you. And thank you for all being here, and I apologize for the rain, although I can't be held responsible. So pulmonary hypertension is a scary topic. Anybody who has a pulmonary hypertension and needs a lung transplant is a very scary anesthetic induction. And there is a literature around general anesthesia and pulmonary hypertension showing that these patients presenting for non-cardiac surgery independent of pregnancy have a morbidity of up to about 45 or 50%, cardiorespiratory morbidity, and some theories showing a mortality of up to 10 to 15% just from having general anesthesia and surgery. And the numbers in OB have looked even worse for reasons that we'll talk a little bit about, but are probably better now than they used to be. I have nothing to disclose. Pulmonary hypertension is defined simply as a resting mean pulmonary artery pressure of greater than 25. For those of you who remember what numbers you used to get from PA catheters that almost no one ever uses anymore, normal PA systolic pressure is in the 20s. So if your PA mean pressure is above 25, then you're said to have pulmonary hypertension. This is a well-described, studied syndrome with many causes. When you read about it, it's often difficult to know which version you're talking about. Talk a little bit about that in the next couple of slides. So this is from kind of a summary of the most recent publication of a system of classification. Pulmonary arterial hypertension, which is talked most about, which is most often idiopathic, but can be due to some of these other causes I've listed. There's another 4 categories. Type 2 pulmonary hypertension is typically called post-capillary, which is due to left heart disease, where the pressure rises in the left heart and is transmitted back through the lungs. Then there's pulmonary hypertension due to lung disease and hypoxemia, pulmonary hypertension due to chronic thromboembolic disease, and then finally, as in all medical classifications, a grab bag of things that we don't really understand that are multifactorial. I just put this up for completeness. The previous slide was a summary of this. So there's a lot of causes, and the responses of different types of pulmonary hypertension to different therapies can be quite different. So I'll be talking more about the type 1 or the idiopathic pulmonary hypertension, which is probably the easiest to kind of understand. The estimated incidence of this type 1 pulmonary hypertension or primary pulmonary hypertension is about 15 per million, which doesn't sound like very many, but you come up with about 60 per 4 million, which is about the Bay Area. And patients who have pulmonary hypertension in the Bay Area are going to come to probably UCSF or maybe Stanford. So that's 60 a year if they're pregnant. So they're certainly going to see it. How many of you have seen patients with pulmonary hypertension in your population? So lots of you. So it is something that's quite relevant, even though the incidence of this primary pulmonary hypertension, which is one of the many causes, is relatively low. What you can see here, of course, is also very relevant to an OB anesthesia crowd. The mean age is childbearing age, and there's a female to male predominance. And with the diagnosis of primary pulmonary hypertension in the past, and hopefully this is improving now with better therapies, the mortality is up to 15% in the first year after diagnosis. And this is independent of pregnancy. Hard for you to read this slide, but this is showing the survival of patients from the onset of diagnosis of pulmonary hypertension depending on the diagnosis. So the top curve is for patients with congenital heart disease, the bottom curve is for patients with HIV, and primary idiopathic is the second from the top curve. And so you can see at 1 year we're getting down to a sort of a 60 to 90% survival, and at 3 years if you have primary pulmonary hypertension you're in the 65%. So this is not a very nice disease. It's a disease that leads to mortality, and if the patients are possibly can be considered for a lung transplant, that is typically the only thing that saves these patients from mortality. So let's talk a little bit about some of the definitions, the hemodynamic definitions. So I mentioned on the top line here, if I push a button, can I get a pointer here? Let's see. If I push a button, do I get a pointer? I don't want to make some. That one, okay. Don't want to make anything change. So, sorry for those of you looking at the other screen. Mean pulmonary pressure of greater than 25 is the definition. So precapillary pulmonary hypertension is where your left ventricular end diastolic pressure, or your wedge, is less than 15, but you have a high calculated pulmonary transpulmonary gradient or pulmonary vascular resistance. So the transpulmonary gradient is the mean PA pressure minus the left atrial pressure. And if you have a high gradient there, it means that it's coming from precapillary. It's coming from the pulmonary arterial system itself. The calculation for pulmonary vascular resistance is called Wood units, and that is simply mean PA pressure minus left atrial pressure divided by cardiac output. You're probably more familiar with Dyne centimeters, which is what we use for systemic vascular resistance, and that just takes Wood units and multiplies it by a factor of about 80. But Wood units is what the pulmonary doctors use. And normally, normal pulmonary vascular resistance is 1 or 2 Wood units, and when it gets above 3, then it's abnormal, which is what you see with precapillary pulmonary hypertension. Postcapillary, such as would be due to left heart disease, would be where your wedge is elevated, but the transpulmonary gradient is not so high, nor is the pulmonary vascular resistance. And of course, as in everything in medicine, we have patients that have components of both. And these would be patients with diseases such as HIV and connective disease. So primary pulmonary hypertension is typically the precapillary, and left heart disease and congenital heart disease is often postcapillary pulmonary hypertension. What's the pathophysiology? Again, this applies mostly to primary pulmonary hypertension where there isn't another known inciting cause. This is, if you like, idiopathic, meaning we don't exactly understand what exactly the causes are. But it's essentially a combination of endothelial dysfunction and vascular remodeling on top of a patient who has a genetic predisposition. So it's probably the more than one hit hypothesis. So they have an excess of proliferation over apoptosis in their pulmonary vasculature. It's mostly at the small resistance vessels. There's chronic inflammation and thrombosis in situ. And as I will mention later, one of the mainstays of treatment for patients with pulmonary hypertension is to try to reduce the thrombosis, so these patients are often on anticoagulants. And then there's something that we can treat, which is vasoconstriction, active vasoconstriction, but you can see a disappointing number of percentage of patients are actually have this active constriction that is responsive to vasodilators. So these patients are subjected to a test in the cath lab to see if they're responsive, and if they are, then they may be placed on a vasodilating drug, but many of them are not very responsive. So this is a figure that you probably can't read, and I'm having trouble reading the screen here myself here, but essentially this is from a review of pulmonary hypertension, and what it shows on the top here is you start out with a patient who has a genetic susceptibility, then there's acquired factors which are related to chronic inflammation and a variety of disease states, and then you have a combination of pathological growth factors in the pulmonary vasculature, extracellular matrix abnormalities, and endothelial problems. And it's really only at the endothelial level that we can give therapies. The therapies will help vasodilate. And so what's listed here, which I still can't read here, are prostaglandins are reduced, vasodilatory prostaglandins are reduced. The actual amount of and response to nitric oxide is reduced in the pulmonary vasculature in patients with pulmonary hypertension. And finally, they'll have an abnormal endothelial response to endogenous endothelial dilators. And so they may respond to an endothelin blocking drug, such as something called bosentan. So how do these patients present to you if you see them in the prenatal stage? Or hopefully they don't present with their pulmonary hypertension at the time of delivery, because that can be a real challenge. So typically these patients will present in their day-to-day living with kind of general symptoms of heart dysfunction, dyspnea, fatigue, maybe some chest pain, maybe syncope or edema, and maybe palpitations. And what this all is referring to is right heart. And you heard in the last lecture a little bit about right heart dysfunction with pulmonary embolus. Similar considerations here. And what causes patients to acutely decompensate and die in pulmonary hypertension is right ventricular failure. So many of these are signs of right ventricular dysfunction or failure. So when patients develop these, some combination of these symptoms, then there is an algorithm for doing a variety of tests increasing in invasiveness. And you can't read this on the slide, but you can hopefully read it in your handout. This is from a nice review from 2009, starting with a good history, examination, chest x-ray, and EKG, and then leading to an echo. With an echocardiogram, when you measure, if the patient has a tricuspid regurgitation jet, which most people do, a small jet, and some patients will have a bigger jet, if you can measure the velocity of that jet, the velocity is proportional to the pressure difference across the RV and the atrium. And that pressure difference lets you estimate the right ventricular systolic pressure. So when you measure the velocity of a tricuspid regurgitation jet, you can actually estimate pulmonary artery systolic pressure. So that's why this is such a good test. And of course, it also looks at the anatomy of, the size of, the contractility of the right ventricle. You may go on to a VQ scan, and you can see as you follow down here with additional tests, depending on what you're finding. So there is a nicely worked out algorithm if your patient presents with symptoms that may suggest cardiac dysfunction, and maybe suggest, especially if there's some peripheral edema, right heart dysfunction, an investigational algorithm to follow to see if there might be some pulmonary hypertension. What should you do if this test comes back, or if you refer the patient back to a primary physician and say we want to do an echo or look to see if there might be pulmonary hypertension? Number one is, it should be in red. Management of these patients is not straightforward. And management of these patients can really impact the outcome of their pregnancy should they go through with it and their delivery. And so involvement of a pulmonary hypertension specialist, not just a pulmonary doctor, but a pulmonary hypertension specialist, is really important in these patients. So depending on the clinical presentation and the findings on right heart cath and echo, they may go to the cath lab and be given vasodilator challenges to see if they're responsive. And if they are, then they may be started on pulmonary vasodilator therapy. In general, outside of these therapies, the management of pulmonary hypertension and right heart dysfunction is regular examinations, history, physical exam, close monitoring of fluid status and weight, which is of course complex in pregnancy because patients are gaining weight because they're pregnant, and possibly administering diuretics to avoid right heart stress or as the blood volume increases over the course of pregnancy. As I mentioned, antithrombotic treatment, anticoagulation, and as I already mentioned, close follow-up. So what are the pulmonary vasodilators that can be used? There are several pathways of pulmonary vasodilation, and so there's several possible drug interventions. So these are the oral and inhaled dilators. The oral pulmonary dilators are sildenafil, which you know has other uses, but it's actually a pulmonary vasodilator, and other drugs of this class with different durations of action are similar, but sildenafil is the best studied and the best validated. If the patient shows reactivity when they're investigated, this is a likely medication because it is quite effective and it's oral. In some patients, there can be responsiveness to calcium channel blockers, which are even less expensive. So this is a reason to consider these drugs. And then there is the third class of drugs that can be used are the endothelin receptor antagonists. So endothelin is a pulmonary vasoconstrictor, and you can give these drugs which are quite well shown to be effective. Problem with these drugs is that they are teratogenic. So if your pregnant patient is on this drug or your patient develops pulmonary hypertension, this is not a category that can be used in pregnancy. Then there's inhaled medications. The two commonest drugs that we use are approved for this, nitric oxide and inhaled prostanoids, which work through different mechanisms of actions. You can give both, but most centers, if they're treating these patients, usually for acute exacerbations, because this is not a home therapy, would be nitric oxide or prostanoids. There are two different prostanoids that can be given by inhalation. So your patient could be on this, and this is actually more used in Great Britain than in North America. And then finally, there's the intravenous prostanoids listed there, epoprostenol. Milrinone is actually a phosphodiesterase inhibitor, which can help maintain levels of cyclic AMP within the cell and vasodilation. Isoproterenol, which is almost never used, and nitrates can have a mild effect. The problem with the intravenous agents is that they're not pulmonary specific, and that is that you will get systemic vasodilation. And the worst thing for a failing right heart is hypotension. So you have to be very cautious with the intravenous agents. So if you're managing a patient in the operating room with pulmonary hypertension, it's much safer to use an inhaled agent because then you won't get the systemic hypotension. So that's just a little bit about pulmonary hypertension in general. And as I push the button, oh, there we are. And the final thing, as I mentioned already, is that we really are trying to manage the patient so that they don't develop right heart dysfunction. Because once right heart dysfunction sets in, the patient becomes acutely ill and acutely an issue for intensive care management, advanced therapies, inhaled therapies. And if somebody is in right heart function, is in right heart failure, and they happen to be 30 weeks pregnant, and you try to induce labor, you're likely to cause very bad things. So the treatment is to maintain right heart function, volume status, anticoagulation, and then progress in appropriate safe management of the pregnant patient for delivery. So these two slides are off the web because I don't have an OB textbook anymore. But they show you what you all know better than I, and that is, on this graph, we're looking at the percentage change in plasma volume and blood volume and red cell volume. And what you can see is that 30 to 40 weeks is when the maximum is reached, but there's a rapid rise over 20 to 30 weeks of pregnancy, actually over the whole course of pregnancy, but the rise is really getting to be impressive in the second trimester, towards the end of the second trimester. And this is the cardiac output, stroke volume, and heart rate, and you can see the same thing here. In the second trimester, it's reaching its peak up towards 27 to 30 weeks. So not surprisingly, this is when patients with pulmonary hypertension tend to get into some trouble. They get more symptomatic, and they're more likely to come to your attention if it hasn't been diagnosed. And if it has been diagnosed, this is when their pulmonary hypertension specialists are talking about getting them admitted for closer watch in the hospital. So I've got here a few studies for you going back to the 1970s and going up to the current decade. And this is a kind of a scary study. This is a review from several studies published from Switzerland looking at the outcome of pulmonary vascular disease in pregnancy. You can see here a very scary mortality. Patients who have pulmonary hypertension due to right heart disease or primary pulmonary hypertension, to left heart disease and right heart disease, And then to other causes, we're up to like 30 to 50% mortality of mothers during pregnancy. And this isn't that long ago. This is about 25 years ago to 30 years ago, but it's before the prostanoids. It's before the widespread use of the inhaled, intravenous, and the inhaled and intravenous prostanoids. This is looking at severe pulmonary hypertension during pregnancy. This is a little more recent. This is 2005. And this, I believe, was 15 consecutive cases in one center in the US. 14 patients, 4 had primary pulmonary hypertension, 5 deaths. Overall mortality 36% in 2005. So this says prostanoids were beginning to be used more. And this is really only 10 years ago. This is a very relevant question. So this is from the European Heart Journal 2009. Has there been any progress? So this is a literature review. This is, again, mostly from European studies, case reports from a whole variety of institutions, 73 cases, and they showed an overall reduced mortality of about 25% instead of 30 to 50%. 25 is reduced, okay? That's kind of a scary number. And they call this still prohibitively high. Interestingly, these patients, when they're in the hospital and managed peripartum by people who understand their disease and where we're giving appropriate medications, the mortality is measurable but is not the full. It's usually about 10 to 25% of the mortality is in the hospital. And a lot of these patients who die, it's postoperative. It's in the first postoperative month. And a common theme is that patients who decide they are going to stop taking their medication in the month or two after surgery. So they need very close follow-up after delivery. And as you know, this is because the cardiovascular changes don't go away immediately. They take some time to resolve. This is getting a little more optimistic. This is published at the end 2008. Improved survival using a multi-professional approach. So this is a single-center review of patients managed by, it's called in the setting of a specialist quaternary referral pulmonary vascular unit. You all have access to one of those, right? So these patients were all getting nebulized prostacyclin in the hospital, and when that was not adequate, 4 of them were converted to intravenous prostacyclin. And in this series of 9 patients, they had only 1 death in that postoperative setting of a patient who decided she was going to stop her treatment. So that's more optimistic, 2008. This is a little chart prepared for by one of our pharmacists at UCSF, Noelle de Leon, who actually happens to be pregnant but doesn't have pulmonary hypertension. And this is the listing of the drugs that we have on formulary at UCSF, and I'm sure similar to your hospitals if you deal with this population. There is epoprostenol, and there's two vendors. One is Flolan, which is the best known name, which is for intravenous, and the newer one is called Velitri, which is a trade name. It's the same drug, but it's formulated differently and doesn't need to be kept refrigerated, and is much easier for the patient to use. And so in 2016, when patients are started on intravenous epoprostenol, we're using this newer version instead of the older Flolan. The other drug that's widely used in the US is a drug called Remodulin, which can be given both, I think I'm sure I say it, I often put one extra syllable in it. I think it's trepoprostenil. And it can be given both by inhaler and by intravenous version. It's not as widely used at UCSF. So these are drugs you need to be familiar with. And in Britain, Iloprost, I think that might be the correct pronunciation, is a common nebulized prostacyclin that is used more in Britain and in Europe. So this is the article which I think is the most recent article. This is 2013. It's a retrospective multi-center experience. It's in USA centers. There were 18 patients who had pulmonary hypertension identified before surgery. And in this study, 6 of the patients were convinced to terminate their pregnancy at 13 weeks. And in those pregnancies, all the women survived. 12 of the patients, 12 of the patients carried to term. They all had C-section at around 34 weeks. The right ventricular systolic pressure in those patients was 82, pretty high. The admission in those carried to term, the date was about 29 weeks at the end of that second trimester when all the blood volume issues are at their maximum. In this series of 18 patients, they had 1 in-hospital death at 29 weeks and 1 at 2 months postpartum. So that's 16% mortality, which is less than 50 or 30. And in those patients who delivered, there was no fetal mortality. The patients were generally hospitalized when they had symptoms. They were given fluid restriction and started on anticoagulant if they weren't already on it. 9 of the patients were already taking a prostaglandin at the time of admission. In these patients, 8 out of 12 underwent epidural anesthesia. 10 out of 12 had a CVP. 1 had a PAC. I'm thinking 1 had nothing, but it's hard to believe that. And during delivery, 4 out of 12 required pressors. Their conclusions, I think the top one is really very important, and of course we don't get to see that, but it's still recommended to these patients, strongly recommended, that they avoid pregnancy, and if they get pregnant, that they should have the pregnancy terminated. The latest study is 16% mortality. That's a pretty high mortality. The mortality with carriage to term is lower than in the past. In the prenatal management, as I've mentioned, the management needs to be by somebody who understands this disease along with their obstetrician. So a pulmonary hypertension specialist. Most of these patients, in fact, in these studies, all of the patients were admitted 25 to 30 weeks with a planned C-section, and the peripartum management team, of course, includes us. Our management has to be in close collaboration with those who understand the disease and the therapies. Don't stop the prostaglandins. Deliveries at 30 to 34 weeks. Epidural spinal anesthesia with a gradual onset, usually a spinal catheter, is recommended rather than general anesthesia. As I mentioned, induction of general anesthesia in a patient with a PA pressure of 80 is a bit of a scary thing, whereas a gradual onset of an epidural can be much more controlled. The patient should be monitored with an arterial line, a central line, not necessarily a PA catheter, and be monitored in the ICU until stable. And this unreadable slide, but is in your handout, is a kind of an algorithm from the British Journal of OB&GYN, just summarizing what I've said. Thank you.